start. We'll start with just a word of prayer. Father, I thank you that we can come together tonight, even across Zoom. We can be together and we can learn some new things together. And we pray for this time, Lord. I pray that you bless each and every person on the call, Father God. We pray for Bev as she has prepared diligently to give this presentation. And we, first of all, Lord, just want to thank you and bless you for who you are. We're grateful that we have a Father in heaven that we can go to make requests and to have fellowship with. So we give you praise tonight, Father God. And we ask, Holy Spirit, that you would be with us, that you would grant us ears to hear what we're going to be talking about tonight, Lord, and hearts to receive. And we bless you, Father God, and we thank you, Jesus, for all that you do for us. Amen. Amen.
Amen.
Okay, so the main focus of this session is to give you some new information. Some of it is pretty new, some of it's been around for a few months.
Yeah.
But I really prayed about doing this because I normally don't do any kind of medical things through Women of the Word. But I felt that this is really important um, to get some of this information out to you and to people so that you can make educated decisions. I've been an RN for 40 years, be almost over 40 years this year. I can't even believe I'm saying that. How did that time go so
I
quickly?
don't know.
Okay, so you have an idea of how old I am now. But anyway, uh, and my background has been primarily in critical care. And, as I was thinking over things and how things have been going with COVID, I thought, when I went to nursing school over 40 years ago, and then through my career, the really big kind of, pillars in medical care are prevention and early treatment.
That's
So,
right.
I mean, we were always taught that
Yep.
prevention, prevent things and then treat early as possible. And this has not been happening with COVID. We were told when this first started, really, that number one, there's no treatment. And number two, no preventative measures have been pretty much out there. Nothing about building up your immune system. And then we were really told that, don't come to the hospital until you can't breathe and your lips are blue, kind of thing. And that just isn't, you know, that's not how medicine has been. That's not how I learned it, right, Bev? Did you learn? I mean, we
That's right.
do things that way.
Yes. Yeah.
So as we've done, as I've done some research and then Bev and I happened to meet and we were talking about some things. And then Bev actually had COVID herself last summer. She may share a little bit about that. And as we've been talking, I really, we both felt, hey, let's just get some information out there. We are not giving you medical advice in the sense of we're not telling you to do anything except take this information and then go talk to your doctor about it. All right. So we're not doctors. And I just want to make that really clear. So we're
Right.
we are not giving you prescriptions or telling you what to do. We're sharing some information that you should that so you have some other information you can go and share with your doctor.
Yeah.
Now, Bev has been also a cardiovascular ICU nurse during her career, as well as a research nurse. She did medical research. So when she has looked at the things that we're going to be talking about, she has even more experience than I do because she knows how to look at medical research and what to look for, how studies are put together, that kind of thing. Okay, so we're really just here to share information with you,
That's right.
and And Bev has some of this, and has watched through COVID herself and was quite ill. And at that time, really didn't even have some of the information that she's going to be sharing
Right.
with you today. So, without really any further explanations, I think I'm just going to say, Bev, go for it and
Okay.
share your information, and just let me know when you want me to, screen share
Okay.
the things that you need. Okay.
Yes. Okay. So it's so nice to see everyone here tonight. And I just am grateful to have this opportunity because for me, as a nurse, I'm retired. To see the death toll rising the way it is, and I knew back in the spring that come winter, fall, winter, if we didn't get some treatments going, we were going to really see things skyrocket in the wintertime. And that's some of the things we're going to address tonight. So, what's going on right now, we have people who think, oh, no big deal. I don't, I don't need to wear a mask. And other people who are very upset if people don't wear masks. And so we have this broad spectrum of kind of everybody doing their own thing. And so this is to give you information. And what I found, I love teaching patients. What I found, if they understood the disease process, it made them much more compliant with doing prevention, taking their medicines, and so forth. So this is just to give you some understanding. And then to let you know that there are some sites. So most of this was taken information I've gathered over the months. And for some reason in January, God just put an alert and alarm in my heart when I first heard about the Wuhan situation, where the first outbreak began there. And I immediately thought it's coming. And as soon as we started bringing people back home, which we wanted to bring them back home, I knew we were just transporting the virus back here. And so I really began to just look at whatever information I could find out about it. It's just, I never really wanted to be a nurse, believe it or not. But it turned out, as God would have it, in directing your steps, that I ended up loving ICU nursing. And just as a background to ICU, how ICUs got started was many, many, many decades ago. Doctors found that patients who were closest to the nurse's station did better. And it was because they were responded to much more quickly. And the more they saw this happening, they started congregating the sickest patients up towards the nurse's station. And eventually, what evolved were these intensive care units. And as these intensive care units developed, nurses began getting more and more responsibilities, and the doctors started training them. And there are just wonderful history of physicians training nurses to read EKGs and to start IVs. And it was only doctors who could administer blood, and so then they were administering blood products. And so ICU grew over the years, and the nurses became more and more educated, and the doctors were really tremendous in spending time and teaching nurses. So that's kind of the background. And of course, what we found in the hospital, that the sooner you responded to a patient in crisis, the better chance they had of surviving. And on top of that, then what developed was that we started to monitor them more closely. So we would put them on heart monitors, and then eventually we got these, if you've been in the hospital, if you've seen somebody in the hospital, these little probes on the finger, we could monitor their oxygen saturation. And so we got more and more adept at looking for signs and symptoms of things changing in that patient's condition. And what we found was that the sooner we responded, the better they did. And the real goal was to pick up on changes before they really started to kind of snowball, and that you intervened early. And when we were in nursing school, as Betsy said, the question was, who gets sick? Well, the very young and the very old. They're the weakest. Kids can get sick very, very quickly. I actually did some training in open heart pediatric open heart patients, and they would just like that, on a heartbeat, they would just be going down the tubes, as we used to say, not doing well. And the very old or the elderly, and it's hard for me to think that I'm now considered part of that vulnerable population, but there we are. You know, time passes fast, and here a lot of us are. And so, so the very young, the very old, people that have different, maybe genetic diseases or predispositions to getting illnesses. And so I knew very early I was vulnerable because of my age. And the age is important because our immune systems don't function as well as they did when we were 20 years old. As time goes on, our immune systems weaken. And so a lot of what we're going to talk about tonight is what we can do to boost our immune systems and strengthen them. And then along with that, the people have autoimmune diseases, and people have heart disease, and they have diabetes, and all of these are what we call comorbidities or risk factors, so that they're much more vulnerable to getting respiratory illnesses. And so it depends on how well people are compliant with their medications and keeping their blood pressure under control, their diabetes under control. And so a lot of medicine is, you know, treating diseases, providing medications to stabilize things like cardiovascular disease, blood pressure, heart rhythms, diabetes, keeping your glucose in a good range. And so all of this, we focus on really trying to prevent disease. And the other things that causes disease is if you separate dis-ease. So that goes to when we're under a lot of stress. And if many of you in the workplace, you know, in the fall, the kids go back to school, they come home, and they start bringing the cold virus back home. The parents go to work, and then the cold virus starts spreading at work. And so who gets sick? And you know that many of you have gotten just a common cold because you were working really hard. You're working all day, you come home, you make dinner, you're trying to get the kids out to their activities. You're out until 8 or 9 o'clock at night. You come home, you go to bed, you get up, you go to work, and you get on this treadmill and then you get worn out and run down, and before you know it, you're becoming ill. So a lot of what we do is to try to prevent illnesses. And in terms of this, what we're going to talk about tonight is what I began finding. I knew I was at risk because of my age and decreased immune system just by virtue of age. And then I also have a cough variant asthma. I have very reactive airways. And so if there's a respiratory type virus around, my body will find it. And so I knew I was going to be at risk just for that. So I was really heightened as to who was going to be vulnerable in this. And God was very good to me. And as a nurse, it was like I had a sixth sense for not wanting to be a nurse. I didn't know how I knew what I knew half the time. And it seemed like I would end up in the patient's room just at the moment they were trying to crawl out of bed or something was coming apart. And so there was a real favor of the Lord on my life. And he gave me just a real knowledge. And I had great training. under great physicians in academic hospitals. And I started out in the ICU, and I ended up in research in my last few years of work. So what I want to give credit to tonight are the doctors who have posted these videos on YouTube. And so I'm going to refer you to that. And those of you who are nurses or have a medical background, you might find them very helpful. But there are two particular physicians that were really very instrumental in the beginning that I found right away. And one is, his name is Dr. Schwartz, Roger Schwartz, and he is a pulmonary critical care intensivist out in California. And he has a website called MedCram, MEDCRAM. He's a phenomenal teacher. If you know any medical student or nursing student, I wish I had had his site when I was learning a lot of my critical care nursing. And he began immediately really looking at the coronavirus and looking at past research studies that had already been done, and then looking at the pathophysiology of the disease. How did this virus, how does it get transmitted? How does it work in our body? How does it function? And it was unbelievable. And once you understand that, then you will understand why we're going to be showing you some of these supplements that really were critical for me in really, I think, surviving COVID. And then the other physician is Dr. Paul Marick, M-A-R-I-C-K, Dr. Pierre Corey, who just testified before a Senate subcommittee to try to push for early treatment in the disease. And they have a website, flccc.net, from which you're going to see some graphs that we're going to post during the presentation, so that you can go to that site and look at this information. And these guys are the top cream of the crop. I mean, these are pulmonary critical care physicians are managing very, very sick ICU patients. And they very early on found that they were, they found very, very early on that the ICU patients that were and the patients who were being hospitalized were extraordinarily sick and were dying. As you remember the New York case, where it was unbelievable, the hospitalizations. And so they began gathering together, Dr. Paul Marick started gathering together 9 physicians around the country who were experts in their field, all academics in research. Between all of them, they have like 2,000 published papers. And so they knew how to look for the research, and they began realizing that unless we start treating people early, we're just not going to make any headway. And so they started looking at studies that were being done around the world, who was surviving, who was having success. And so, so that's the background where I began learning way back in the very beginning. And so what I'm going to do now is, so one of the things we want to look at in who is at risk, particularly for this virus. And this will be true of any respiratory virus, like the influenza virus, the cold virus. The cold virus is another type of a coronavirus. And so particularly with COVID, we know 65 years of age and older, because we have weakened immune system. And the more our age increases, the greater our risk becomes, and the greater our chance of dying from the illness if it's not treated early. For some reason, males have a propensity for getting sicker, and more males are sick. We have learned that they thought initially that people like with asthma and pulmonary diseases, we're going to be filling the ICUs. And that ended up not being the case. What they found was obesity was a big factor. And we have a measurement we call BMI, or body mass index. And that's a calculation based on your height and weight. And there are ranges. And so if you have a BMI greater than 30, you're at a high risk of getting COVID. And in America, obesity is an incredible, it's like an epidemic. And in addition to that, and by the way, there's, if you just put in BMI calculator and search that, you can come up with a calculator and find out what your BMI index is. And so you want to at least be below 30. I think if you're 25 or above, you're overweight. And then once you hit 30, you're considered obese. And then 35 or greater is morbid obesity. And in addition to this, they started finding that their ICUs were filled with people of color, the darker the skin. So Hispanics in our country, and African Americans in particular were at risk. And there's a reason for that. And it's not because, you know, of access to healthcare, although that's an issue for many, many people. Also, they started seeing people with hypertension and cardiovascular diseases, diabetes. And so these were some of the people that were at the highest risk. And the more they started looking into this and the research, as you know, we saw it move from Southeast Asia, moving across to Europe, and then Europe over to us. And it was really quite alarming how quickly people were succumbing to this. And it tended to be the elderly and a lot of people with these factors. So I think, Betsy, if you put up the that slide, and what I'm going to go through is how they have found that this disease progresses, and it's really important to understand this. So she's going to put up a slide that is on the flcc.net website, and we'll talk about this disease progression. So number one, it's a respiratory driven virus. So, you know, initially everybody was like washing their hands all the time. And when I went to the grocery store, I was wiping everything down and wiping down my doorknobs and doing all of these things. And it turned out that the transmission really wasn't so much from that. You know, typically like with a common cold, people are coughing, they're sneezing on door handles, they're sneezing on counters and stuff. And if you happen to touch that and then touch your face, you could potentially, you know, inoculate yourself with the cold virus. And so they thought perhaps that was, so they were emphasizing washing hands. As time went on, of course, you know, was wear the mask, don't wear the mask, and so forth. But what we've learned is that this is spread through what we call droplets, macro droplets, like when somebody sneezes or you're talking to somebody and they're close to you, and, you know, saliva, you know, is released from their mouth while they're talking, and it kind of gets on your face. And then as time went on and the research was going on, they found that it was being aerosolized in micro droplets, and that, you know, you heard about people who sing or shout or whatever, that it was really going beyond 6 feet and even up to 20 feet. And so it's definitely spread through the breath and coughing, sneezing. But what I noticed when I was out and about very early, and to this day, I don't hear people coughing in the stores or sneezing in the stores. And so I'm thinking it's got to be more from our breath, and it's probably more infectious than we really understand. And it seems to be that that is the case. So typically we're going to just talk about the progression of the disease on this slide. And there are 4 main stages. There's the incubation stage. You'll see it at the top of the screen here, stage 1. And then there's the symptomatic phase. Then there's the early pulmonary phase. And then there's the late pulmonary phase. And you're going to see this bar with severity of illness. And then you're going to see at the bottom, it'll say time course in days. And I just need to move my screen here a little bit so I can see. So I want you to look at this dotted line and see how it is right at the baseline at the very beginning, and then it begins to rising up, and till at the end of 28 days, it is like way off the chart. That is severity of illness. So in the beginning, people don't feel bad. In fact, people are exposed to the virus. They don't even know they've been exposed. And there's no symptoms going on in these first 5 days. And if you see the viral replication diamond, it's very narrow in the very beginning. So when you're first infected with the virus starts slowly replicating. It replicates in your nasopharynx passages, primarily in the nasal areas and the soft palate in the back of your throat. And it starts ramping up very quickly, multiplying by the millions of viruses in your nasal passages very, very quickly. And so you'll see that there's a bar right before day 5 in the diamond. And it peaks in viral replication just before you get symptoms. And so when you get symptoms, you are at peak viral load. And then the virus begins to slowly drop off in replication. And then you'll see about midpoint, the viral debris, the virus then begins to die. And it's the dead viral tissue that is causing the real problem. So in the incubation phase, you don't know you have the disease, you're around people, you don't know if they have it. And so I know masking is controversial with a lot of people. And you see the people that wear the mask beneath their nose. Well, guess where the virus is rapidly progressing and multiplying is in your nasal passages. You want to have your nose covered. And so in the meantime, as it's replicating, we're aspirating some of this virus down into our lungs. And that's how it's getting down into the lungs. Through postnasal drip or, aspirating a little bit of saliva. And at this point, the symptoms begin around, say, day 5 to 7 after exposure on average. And everything is kind of in flux here. And some of these symptoms you've heard about them. You might get a fever. You might not get a fever. You may get a dry cough. You might get a sore throat. You might get just a strange kind of a nasal running, and just body aches. You don't feel well, and you might get some diarrhea. And we'll talk about why you might get diarrhea in a little bit. And so, depending on your immune system, you may have very, very mild symptoms. You may end up being an asymptomatic carrier where you're just not going to get sick. And so in the incubation period, about 20 to 40% of people never get symptoms at all. And so it's asymptomatic spread. They have the virus and they don't know it, and they can pass it on to somebody else. And then we go into the symptomatic phase. And really, honestly, the good news is that about 80% of people really are going to do well and not need hospitalization. But there is a 20% of people that will require and move into getting more ill, seriously ill, and require hospitalization. And so in the beginning, what we were looking at, Dr. Schwartz was really looking at how can we minimize people from moving into being part of that 20% and moving into the hospital. What can we do proactively to prevent that? Now, some people are just going to be at high risk based on their comorbidities like diabetes and hypertension, but you can mitigate that. There are going to be ways that you can actually put the odds in your favor by doing some very simple things. At this point, during the symptomatic phase, this will, again, you may have mild symptoms or they may just really start ramping up. And during this phase, from phase about day 5 to around day 8, around day 8 to 10, 11, this is kind of a transition point because it's the dead virus that the body begins reacting to. And so you'll see the transition around day 11 that it moves from the viral stage and it becomes an inflammatory disease. Because what happens is, you can see in the viral replication diamond that just before day 11, the virus is falling. It's no longer replicating. Now it's dying. And if you try to treat a virus at this point, you're treating a dead virus. So the antivirals no longer work. And this is something that Dr. Merrick and his team really, really have honed in on, because a lot of these treatments that were being done very late. They were antivirals being used when the virus was already dead, when people were in the ICUs in the hospital. And so, I mean, I think this slide is phenomenal. And again, it's on their website. In the meantime, you have your own innate immunity that we all are born with. And depending on how strong your immune system is and how it kicks in, it also is a predictor of how you survive. So typically when we get sick, our white blood cells kind of mass together to fight and attack the virus. But what happens then is, and I just want to just stop here for a second, that around this time in the symptomatic phase, I want to talk to you about a little device you may have heard people talk about, and it is what we call a pulse oximeter. And that's that little probe that you see on people's fingers when they're in the hospital and they're on oxygen. Well, they're monitoring their oxygen saturation level. And we do that in the hospitals. This is a portable one. You can get this on the internet. They're relatively cheap, around $30. This is essential to have on hand. And the real key to this is being prepared. You have to be prepared and think, I might get sick. And if you don't get sick, oh well, you're not sick. But if you're sick, you want to be ready. That is the lesson of our time in the ICU. You want to be ready to act right away, because this can come on fast and furious if you're susceptible. So I'm going to just show you, stop here a minute, because in the symptomatic phase, you want to have one of these on hand and start watching what your O2 saturation is. Okay, so I'm going to just put this on. There is a little button right here. I'm going to just press that on. It just opens up like a clothespin, for those of you who knows what clothespins are. So can you see it, Betsy? Okay.
Yes.
Okay. So it's going to give you a waveform. I'm just thinking, my heart rate's tacking away here pretty good. I took some of my asthma medications that increases my heart rate, and I'm speaking. But anyway, you'll have a waveform on this. I don't know how clear that waveform is. Let me get it.
Yeah, we can see it.
Okay. You have
you
to let
up
it,
there, Bev.
Rest, yes, right. You have to let it rest on your finger for a little while. You'll see my O2 saturation is 98. That's a great O2 saturation. My heart rate needs to come down. So you want to see a nice waveform like that. What you want to do is, while you're well, get the pulse ox, practice using it, see what you typically run, okay? Because we always go by changes and trends. And so you look at what your baseline is. So my baseline heart rate is normally in the 70s. And so you just take note of that. And you should be running somewhere between 97 to 99%. And if you use supplemental oxygen, you just know what your baseline is with that. Because what will begin happening around day 8, if you're not improving, is that your O2 saturations may begin to fall. So that around day 10, 11, some people are starting to like feel short of breath. Now, the thing that was a mystery in the very beginning was that, they told people not to come to the hospital until they felt short of breath or their lips turned blue. And what they found was when the patients were coming to the hospital, they were sitting, texting on their phone, calling people. And when they put this probe on, their oxygen saturation was like 77%, 80%. But some of these, the levels were so low that the doctors were astounded because people that normally have oxygen saturations that low are like not responsive. And so there began this thinking, it almost acted like altitude sickness. So what was happening was as the viral debris entered the lungs, it caused the immune system to go into hyper overdrive, and it flooded the lung tissue with neutrophils or white cell fighting cells, and they were just flooding the lung tissue, and this inflammatory response was happening. So, just think about what happens to your finger when you get it caught in a door. It starts swelling, it hurts, it's inflamed. That's happening inside of our bodies when inflammation occurs. And so what's happening is it's either they're getting a COVID pneumonia at this point because it's being flooded by these neutrophils. The other thing that's happening is the vascular area around the lung tissue is becoming inflamed, and it's releasing a factor we call von Willebrand's factor, which increases clotting. So you've heard about clotting issues with COVID, and that's because of this inflammatory response. And so a lot of the treatment is now going to switch from the fighting a virus to antivirals to now they have to move into treating this inflammatory response. And then if they don't get control of it in this phase, you can see what that black line starts going around day 14. These patients are getting very, very ill and requiring the ICU, and they're really trying to avoid putting them on the ventilators. And they're using all kinds of treatments. They do what we call proning people, where they put them on their bellies, and then it's just that, the way our lungs are, it's to get the oxygenation to other areas of the tissue and open them up. So this is the real problem here. And these doctors have done a terrific job. And I think this graph is really good. You see this thing called cytokine storm. And that is really when the immune system is so revved up that it is just sending you into oxidative stress. And patients very rapidly begin to deteriorate, and then they have a long course in the ICUs. And the doctors were very disheartened. These doctors, the FLCCC stands for Frontline Critical Care, Frontline COVID-19 Critical Care Alliance doctors, these pulmonary critical care physicians, they were losing patients, and they really were the first ones that started using steroids in the ICU because of this inflammatory response. They were doing that before it was even recommended by the World Health Organization. Eventually, what happened with the Solidarity and Recovery trials, they found that dexamethasone was of use. And this is why, is because it moves into this inflammatory process, and steroids are the first line of treatment there. And so I'm just going to stop there because then you get into critical care management beyond this point. But I think you can see this progression of the illness to give you some understanding. So below, you'll see they can look at x-rays, and they have this, what we call ground glass infiltrates. It has a specific pattern. The COVID pneumonia has a very specific pattern. If people test negative and they see an x-ray, it has these ground glass infiltrates, they just know they have COVID. And you would hear, a friend of mine was still working in the ICU area, and the doctors would say, this patient has COVID. And in those days, the tests were taking forever to come back, and they couldn't begin therapies until they got, a diagnosis. And so anyway, so we're going to move on from this phase. I just want to see if there's something else. I think, can you think of anything else, Betsy, you want to say here?
Well, I was just going to say to people, a lot of times what happens is I have a friend whose son just had COVID, and so around day 8 or so, he didn't have fever anymore, no more fever. So people think they're getting better, and they may get better. But if you're not feeling better, this 8 to 11 days around there is really when it's very critical that you have this and that you check it, even if you're breathing okay. If you're not feeling too good at day 8, like day 8, you need to be checking in your oximeter. I mean, I would get this ahead of time, like Bev said. Like, I have one now. I checked what my normal is. I know what my normal is even before I'm sick. And people that have like COPD, for example, they're going to know your oxygen saturation normal level is going to be lower. It's probably like 88 to 90.
Yeah.
But for normal people, you should at least be at like 95. Okay. And if you are checking this, a couple times a day as you're sick, if you start seeing that number creeping down 90, 94, anything below like 93 or less, you need to be calling your doctor, because you may, like, I don't feel any sicker, but if this number is trending down, you need to be calling your doctor. You don't want to be waiting till this number is like 85.
That's
or
right.
88 even. 90, if you're starting to drop down, that's why it's important to have this, because listen, I've seen even patients in the ICU, and my daughter has been taking care of COVID patients. Like Bev said, I have a cousin who's an ER nurse, and she said to me, they're sitting there fine, talking on their cell phone.
Right.
They seem fine, and bang, all of a sudden they're down. Okay. So this really is a very important measurement, and don't, you have to leave it on your finger for a couple minutes, I mean, let it sit there till you get a good reading. And certainly if your fingers are cold or blue, you don't have good circulation, that can be an issue, but you
got to warm them up.
You got to warm them up. Exactly. But
no nail polish.
No nail polish. Exactly. So that's right. Another good point. No nail polish. A lot of people wear nail polish these days.
Now,
all right.
One of the things I just wanted to say, the reason why diarrhea is because I'll just quickly, the virus, and this is important for the supplements, the virus is replicating, but what's happening? Well, the coronavirus has these spikes on it that makes it look like a crown. The spike, how does the messenger RNA of the virus get into our cells? And it primarily gets into the cells in the lungs and the GI tract. And that's because there's a receptor that's known as an ACE2 receptor in our bodies, and it's actually throughout our vascular system. And so what happens is if you think about the space shuttle, like the NASA space capsule going to the International Space Station, it has to dock into that International Space Station at a certain point where the docking is so that the astronauts can move from the space capsule inside into the International Space Center. Does that make sense? You hear on NASA, they're docking now, so the spike protein is coming into the surface of the cell where this receptor is, and it's docking in, and there's a protein on the surface of the cell membrane that actually opens up that cell membrane, and then the RNA virus of the COVID virus just slips right down into the cell. And this virus takes over, it basically hijacks our cells. And it says, you're working for me now, I'm the boss. So instead of making more lung cells, you're going to make more virus cells. And in the viral replication phase, this really starts ramping up. And that's going to be important because there is a protein in our cells that gives the code for viral replication, and the messenger RNA of the COVID virus takes over, and it begins giving the instructions to make the COVID virus. But there is something that can block that protein, and that something is zinc. And we're going to talk about the importance of zinc in a few minutes. But the reason why diarrhea is there is that these ACE2 receptors are in our GI tract. And so some people have nausea and abdominal pain as part of their symptoms of COVID. And some people just have strokes. They just show up at the hospital with strokes. And some people in their 40s, initially in New York City, everybody was a surprise. So the other thing these doctors want you to know, this is not the flu. It doesn't act like the flu. There are different manifestations of this virus. Some people get it really bad, some not so bad. It can hit the brain. It can be throughout our bodies. And so what we're going to go into now is this protocol that they came up with, because these doctors were watching their patients die in the ICU. And they thought, if we don't do something different, we're losing the battle here. And so they started looking at what was being researched around the world, who was having success, what regions were doing well. And overall, and I will say, for my story, around, I want to say March, April, Dr. Schwartz, on MedCram update number 59, he gave a list of supplements that he was taking himself because he was working in the ICUs, the COVID wards, and he needed to protect himself because he was in high viral loads. And so the vitamins that he came up with were what you see up here, and we'll go through them. Vitamin D3, vitamin C, quercetin, zinc, and melatonin. I don't think he recommended melatonin at the time. And all of this has really progressed over these 9-10 months that these doctors were looking at this. And ivermectin is now becoming, it's an FDA approved drug already, but third world countries were using ivermectin, and we'll talk about that a little bit, but I want to focus on the supplements for you so you understand. So vitamin D3, and I didn't have any of these doses at the time. I didn't know what to take, how much to take. And so they kept talking about vitamin D3 because there was research study that were done years ago where they combined about 25 randomized controlled trials looking at vitamin D3. And they found that, sure enough, people that were taking vitamin D3, particularly through the winter months, for about 6 months, had a 50% lower incidence of getting influenza. They just didn't get it. if they got influenza, their symptoms were minimized by about 25%. So if they got influenza, they didn't get as sick. And it was a really big study. And these doctors started looking back at these studies that had already been done. So I want to talk to you about vitamin D because it's really important. So it's, and during the pandemic in Israel, Barcelona, Spain, they were looking at observational studies at who was being hospitalized. And over and over and over again, the preponderance of the evidence was they were deficient in vitamin D. And so this is number one on the list that you want to have. If you're not taking this, you want to get this. Particularly people of color. We should be having a national program of getting people on vitamin D. And how do you get vitamin D? Well, we used to get it primarily by being outdoors and in the sun. And it turns out that people of color with darker skin, and the darker the skin, don't make it as fast as lighter skinned people. It's a well-known and so just a well-known physiological principle. There are only two ways that you can get vitamin D. It's through the sun and it's through food and supplements. The problem now is most people now, even in sunny climates, spend about only 7.6% of their time outdoors. We are in building dwellers. We work indoors. Many people work in factories that don't have windows. We may go out for a break for 15 minutes, but we're typically not in the sun, we're in the shade. Unless you're a really outdoors person, we just don't have exposure to the sun like we used to. On top of it, with the incidence of melanoma cancer rising, people are using sunblocks. And if you use sunblocks, you can't make vitamin D. And so God is an amazing creator. And this is how it works. The ultraviolet B rays, radiation rays from the sun, penetrate to the deeper layers of our skin called the dermis. And in the dermis is a pre-cholesterol derivative that gets converted into D3. You want to take a supplement that has D3. You don't want D2. You don't want anything that says just plain D. You want D3. And this D3 from the sun, when it's made in our skin, gets transported to the liver. And in the liver, it becomes another molecule. And that molecule is, I won't say it because you won't understand it, but it's what's measured in our blood. And then from the liver, that molecule then goes through an activation process, either in our immune system or in our kidneys. So the vitamin D3 is stored in our bodies either in an active form or an inactive form. In the kidneys, vitamin D3 is essential for the production of calcium and phosphorus. And so one of the reasons why a lot of our foods are fortified is because kids were not getting enough vitamin D in their bodies. They weren't making enough, and they ended up with rickets, with the bowed legs. And then later in life, we can get into problems with osteoporosis, where our bones aren't strong enough. And so you need vitamin D3 to help with that calcium regulation. Vitamin D3 is essential for boosting our immune system. It has, let me just get in here a minute. I need to get to my notes. And it actually, one of the things that I just recently learned is that what is a vitamin? It's a vital amine. So vitamin D3 is essential. You can't get it any other way. And it is also a steroid hormone. It's fat-soluble vitamin. That means it is stored in our fat. So the other issue with the people that are obese or morbidly obese, vitamin D actually starts getting stored in our fat and it's not readily available to us. So that another reason why we're seeing increased risk in the overweight patients. So if they have vitamin D, it's not able to get where it needs to go quick enough. It's being stored in the fat tissues. This fat soluble characteristic means it can easily get into the cell, and not only into the cell, but into the nucleus of the cell, where it can start affecting changes on, of all things, the RNA strand in our nucleus. And guess what? COVID-19 is an RNA virus. So we want to get a lot of vitamin D in our systems, and we want to keep that level up. The meta-analysis that they did on 25 randomized controlled trials that showed an increase in the immune system and decrease in getting influenza. I just lost my place, my thinking. I totally lost where I was going.
Well, the important thing is
you need it.
you need vitamin D3.
Yep. Yep.
So if you're not taking it, you need to take it. And if you are taking it, you got to make sure that you're in this 1,000 to 3,000 range. And I would say the 3,000
Yep.
range versus the 1,000.
Yep.
But again, these things, if you should talk to your doctor about supplements also.
Yes.
But this is what's recommended.
Yeah. This is what these doctors came up to. And this top part of you'll see at the top part, the lower doses ranges is because of, it's the prophylaxis for people that are at high risk. But really, you really want to boost your immune system. And so these ranges are really, pretty good. And vitamin C is really, it's a stress hormone. So we get vitamin C through fruits and vegetables, through healthy diets, and then through supplementation. What's important about vitamin C to know is humans and guinea pigs are the only mammals that don't make their own vitamin C. So when we get sick, we quickly deplete our vitamin C. So when you had the common cold, you took orange juice, and then later on, people started taking vitamin C supplements to kind of minimize the effects of the, common cold virus. And it actually works. Animals who are under stress can make their own vitamin C. Humans cannot. So when you get sick, you really deplete quickly. And they found in ICUs with patients who were critically ill, they just quickly were depleted entirely of their vitamin C. And what happened was Dr. Merrick had just been studying about all the wonderful effects of vitamin C. It acts as an anti-inflammatory. It stops that flood of the neutrophils from flooding the virus. It mitigates that. It affects histamine in our bodies, like for allergies. It promotes wound healing. But the big thing with this is that he just was reading about vitamin C. He had a really sick lady in the ICU, and he thought, let's just try vitamin C. So they came up with an IV infusion of really, really high doses. You couldn't take this much by mouth. And they used it in combination with steroid. And that lady was off all of these blood pressure medicines overnight and ended up with this incredible turnaround and was able to be discharged from the ICU within 2 or 3 days, he said, if we don't do anything, she's going to die. And so that began this treatment of steroids and vitamin C and thiamine in the ICU for sepsis. And it was the combination of those supplements and those medicines. Quercetin is a supplement, and all of these you can get on Amazon or, in vitamin shop stores. They're going with 250 a day. I took 500 twice a day when I was sick. And quercetin is found in the peels, apple peels, onions, capers. As a supplement, it's also a zinc ionophore. So we talked about zinc blocking the virus, the protein that causes the virus to replicate very rapidly. Quercetin is the gate opener in the cell to allow zinc to flood into the cell. So when we're taking zinc supplements, it's just basically circulating, but not readily getting into our cells. And so when I became ill, I hadn't really fully bought on quercetin. I was taking vitamin D3 and vitamin C and zinc. And when I got sick, I thought I should have ordered that this past week when I thought about it, and I didn't. So I quickly ordered it. I got enormously sick very quickly. I got every symptom. I was short of breath. I had the cough. I couldn't finish a sentence when I was talking to a friend of mine. I ended up getting fever and shaking chills. And the next day, my second day, was the worst day. My temperature went up to 105. And I really thought I was going to succumb at that point. And I thought, I really wish I had bought that quercetin. And so I really prayed. I had people praying around the world really for me. And I just basically said to the Lord, here I am. And I did turn the corner that night, and I was using my steroid inhaler at this point, just so I could breathe. I was really struggling with my breath. It was on a weekend. Of course, you can't get any help on a weekend. It was hard. I did go to urgent care, and they basically, did the COVID test. They did an X-ray, and my lungs looked good at that point. I did have a good saturation, but I couldn't believe how quickly I got sick. I ordered immediately the quercetin, and I got that about the third day. And I also ordered a supplement called NAC. And within 2 days of adding those on, I woke up in the middle of the night, and all of a sudden I could breathe. And I knew, and I began turning the corner. My fevers started decreasing as the week went on. So I can attest to all of these supplements because I had all of these, and I was already taking melatonin. Melatonin is an anti-inflammatory. They're saying 6 milligrams. That's a pretty hefty dose. I would start at 0.5 milligram and work your way up. So it's hard to find low dose melatonin. 3 milligrams is usually the lowest I see in the stores. You can cut it up and just see how you react. It also helps you sleep, and sleep is important for our immune systems to function. And then the lower part of this protocol, and again, you can go to the website, you're just going to ramp up all the doses of these supplements. And just briefly, ivermectin is an antiparasitic drug that was developed in the mid-70s and started being used worldwide, particularly in third world countries where parasitic diseases like river blindness, scabies, farmers use it for heartworm medication. People give it to their dogs for heartworm medicines. It's an antiparasitic. It's been used over the decades, billions and billions of doses. It is listed on the World Health Organization list of essential medicines. It's very safe and effective, minimal side effects. They think that whatever side effects you get, it's when the parasites start dying. There was a doctor, I believe, in Australia that started looking at ivermectin and started treating people. And slowly, over the course of the summer months and into the fall, they started giving ivermectin, and people were getting better. And so they are recommending this. The doctor that was in Texas, Dr. Verone, they did a press conference, he was, I don't know if he was on the evening news a lot. Their hospital is giving this to the COVID patients, according to the news conference that they did down in Texas. And they're having great results with it. Initially, the CDC said ivermectin should only be used in a research clinical trial. That has been slightly upgraded. Dr. Corey, who went before the Senate subcommittee, you'll see his video on the website of his testimony there. He was there with another panel of doctors who were just really advocating for early treatment, because at this point, we still don't have any early treatment protocols. And then Dr. Corey also went to the NIH to really advocate to upgrade it so that doctors would feel freer prescribing this medication. So they upgraded it to what they do for monoclonal antibody infusions and convalescent plasma, is that it's neither for or against, kind of a status for it. And so that is basically gives you an understanding of the disease process and why these supplements are so very important, because of their effect on our immune systems. And they synergistically work. So the doctors are saying it's all of them together that's really, really important. And so many of the research trials are just looking at one medicine. They were looking at them, they were giving it late. As I looked up some of the protocols of how they were using things like hydroxychloroquine, they were using it without zinc. They were giving it late in the illness, and it has to be given really upfront and very early if it's going to have any effect. And so this is just something for you to have. It's a site that you can send your doctors to, where they can look at the research, they can look at the data that these doctors have put together. And I can attest that those supplements really turned the corner for me, because when I hit a temperature of 105, I really thought, I wasn't sure I was going to wake up the next day. But thank the Lord, he was with me, strengthened me with a lot of prayers. So I know it's getting late. I'm sorry that was so long.
No, that's, I think what I would like people to really get out of this is that, prophylaxis means preventative. All right.
Right.
So the prophylaxis is not when you get sick. This is before. You're trying to prevent.
That's right.
Okay. And this, some people do use ivermectin for already preventative for high risk individuals. But what I'm saying is you need, if you're not on these supplements, talk to your doctor and see about getting on them. If you do get sick, if you do get COVID, you should talk to your doctor like right away. Again, the ivermectin, it's not like, the NIH, the National Institutes for Health, are saying at least now doctors can prescribe it if they want to. All right. It's not that they're recommending it, but if you send them to this website has tons of doctor information. They can at least look at it. Another place that you can talk to, because again, for ivermectin, you need a prescription, and your doctor may not want to give it to you. So I would talk to your doctor, but you can also go to a website called americasfrontlinedoctors.com, and I'll put that in the chat. And you can have a teleconference with a physician, and they'll take your history, what medications you're on, and now they may not prescribe ivermectin, they may prescribe hydroxychloroquine or something else, I don't know, but that is available. They do charge $90, but it's $90 to actually talk to a physician like you and I are, here on Zoom, to take your history and to get you started on something. But I have been taking vitamin D3 in high doses, like 3,000 units, even before COVID hit, because of as a preventative for flu. All right. But when COVID hit, definitely I was like, I keep taking vitamin D and vitamin C, and then I started the quercetin, the zinc, and the melatonin. I take 3 milligrams melatonin, but people are different. You have to see how you react. How do you react to melatonin? It was like, for me, it was knocking me out. Some people need the help to get to sleep. So,
Yeah.
but again, talk to your doctor, because if you're on medications, there
Yeah.
there can be interactions. If you have like kidney disease, high doses of vitamin C is probably not great for you. So, or really high doses. So you need to talk to your doctor, is what we're saying. All right.
I just would interject about the zinc. I'm taking 30 milligrams, and you might even want to start with cutting that in half, because zinc can, when you first start, it can sometimes make some people nauseated.
Yeah.
But all of these work together to really boost your immune system. And the other thing I wanted to say, after it took me a while to recover from COVID. It was till November before I really felt like I can function. And that's the other issue, is why you have to, all I knew is that I have to hit this hard and fast. And I didn't have anybody helping me, and I didn't have any of these dose ranges. So I just doubled everything. I took 3,000 of vitamin C a day. I was on, I believe I was taking 2,000 of vitamin D3 at the time. And I had stopped vitamin D3 because of other health issues, and I just started it back up. So I was probably really deficient in vitamin D3. I doubled it immediately to 4,000 international units. I started taking 60 milligrams of zinc, and the quercetin I took 500 twice a day. And when I finally got the quercetin, and I took another medication called NAC, that is called N-acetylcysteine, it mitigates that cytokine storm. It helps to, it kind of blocks, it's a chemical thing. It's called a disulfide bond that decreases glutathione in the liver. And it's another depletion of an element that you really need in your system. We used it in the ICU for Tylenol overdoses, and it's a mucolytic. So for asthmatics, they used to actually give it as an inhaler, an old drug a long time ago. Turns out that the quercetin and NAC I still take, because it actually has helped my asthma. So I don't have to use my inhalers quite as much. So COVID was actually kind of a blessing for me, because it actually helped me with my asthma. But it did, with all that, I wasn't taking the doses. I tried to back off on some of the supplements too soon, and because I just didn't know enough back then. And a lot of this information just really has come out in the last couple months, that these doctors have put this up. And when they brought it before the Senate subcommittee in December, I watched the whole, it was, I think, about a 2-hour, I watched the whole thing. And I thought, wow, if I'd had this back in July, I really would have hit it hard. And so when you get sick with symptoms, again, the key is building up your immune system before you get sick. It's going to help you with the influenza virus. It'll help you with the common cold. I even kept Zicam on hand. It's a little lozenge you can take for the common cold. Works like a charm. And when I had the sore throat, and now that I know that it really replicated in the nasal pharynx passages, I was taking the Zicam it's a different form of zinc gluconate and zinc acetate. And I was taking that every 3 hours for the first several days, to just get that extra boost of zinc into my system. So overall, it was hitting it hard and fast. And so the other hope that I have for this is that particularly our wonderful people of color that don't know about the issue with vitamin D supplementation, and that they really need help with this along the way. So tell your friends, the doctors know their medical history and what they need to take. A lot of people have kidney disease and so forth. So a good gift to do is a little baggie with a bottle of vitamin D3, vitamin C, and zinc, and quercetin, just as a gift to somebody. If you want to do something during the pandemic, we have to do something, because we're not going to vaccinate our way out of this anytime soon.